Good afternoon and welcome to the webinar. I'm Kimberly Westrich, Vice President of Health Services Research at the National Pharmaceutical Council. For those of you who are unfamiliar with us, NPC is a health policy research organization. We focus on the role and value of innovative pharmaceuticals in helping patients to achieve better health. Today, we will explore policy recommendations for improving patient-reported measures in oncology and value-based payment programs. These recommendations were actually outlined in a paper that NPC and Discern Health released on February 21st. And today we are bringing together a very diverse panel of stakeholders to consider action steps for actually implementing these recommendations, and they'll be bringing us multiple perspectives. So what are we doing today? I'm going to briefly review the project background, then we'll discuss the policy context of patient-reported measurement, consider some of the benefits and barriers to implementation, dive a little deeper into the project overview and recommendations. That will be followed by a moderated panel discussion and then questions from you, and we'll wrap up with some key takeaways and closing. So the project history, very briefly, the webinar today and the white paper that we recently released were part of an NPC and Discern project to assess the landscape of patient-reported measures in oncology and to identify some strategies for developing or enhancing them for use in accountable care programs. This webinar is actually the third in a series of projects that we have had examining gaps in quality measurement for accountable care. Our presenters today, our session will be chaired by Dr. McClellan and Dr. Ethan Basch, both of whom also co-chaired a September roundtable event for this project, and they're co-authors on the white paper. Mark is the Robert J. Margolis Professor of Business, Medicine, and Policy, and he's the director of the Margolis Center for Health Policy at Duke University. He's a physician and an economist who focuses on quality and value in healthcare. And of course, he's also the former administrator of CMS and former commissioner of the FDA, where he developed and implemented major reforms in health policy. Ethan is a practicing oncologist and professor of medicine at the University of North Carolina, where he directs the Cancer Outcomes Research Program, and he's the Associate Chief of Hematology Oncology. Ethan serves on the Methodology Committee of the Patient-Centered Outcomes Research Institute. He also co-chairs Cancer Care Delivery Research Committee of the Alliance Cooperative Group, and he's an associate editor at the Journal of the American Medical Association. Mark and Ethan are joined today by Teresa Smith, Director at Discern Health, and four distinguished panelists who will be introducing themselves in greater detail later. The panelists are Garth Callahan. Garth is a cancer patient and is also known as the Napkin Notes Dad. Sally Oken, Vice President for Policy and Ethics at Patients Like Me. Andy Baskin, who is Aetna's Vice President, who's the National Medical Director, Clinical Quality, and Ann Fish-Stiegel, who's Director of Clinical and Policy at Biologics. And with that, I will turn it over to Mark.
Great, Kim. Thanks for that introduction. Special thanks to NPC and to Discern for pulling all this together, and the other presenters that you're going to hear from in just a few minutes. And also my thanks to all of you joining us today. This is a very important topic, and you can see from the paper that was released, the focus here is on patient-reported measures, but particularly patient-reported measures for use in payment reforms, in value-based payment, accountable care systems, and approaches that are intended to enable better models of care. It's not the goal isn't the payment reform in themselves. The goal is to do something about the real challenges facing cancer care and particularly cancer care patients today. In traditional insurance, with traditional payments, seems like about no matter what they do, cancer patients are hitting high out-of-pocket cost maximums, can be thousands of dollars for their hospital care, the drugs, the complications that often go along with cancer care. And often they're not getting the right treatment support. There have been a lot of innovations in cancer care, including cancer medical homes, more comprehensive models that involve additional resources that cancer patients can access to enable them to avoid costly ER visits and hospitalizations through earlier contact with nurses or members of a care team. People can help them understand what they're likely to expect in the course ahead and help them avoid some of those costs and complications. But those are often services that are not well paid for under traditional models. So not surprisingly, and you can see this on the next slide, there's a lot of interest in payment models that are intended to support better care. So that's what value-based care should be about, reducing total costs while substantially improving outcomes and the patient experience. And no shortage of efforts underway now to try to implement these successful alternative payment models and better care as a result. CMS has a major oncology care model underway now, one that may get a bit of a reboot or update soon. It's an area where, if anything, the Medicare program is doubling down on trying to support better care models. There have been a lot of ideas introduced by provider groups, oncology experts, including models that have been submitted to the Physician-Focused Payment Model Technical Advisory Committee and to CMS in the form of comments to try to build out the oncology care model and other payment reforms relevant for cancer patients further. And there are a large number and growing number of such models being implemented in the private sector by, for example, commercial insurers. Blue Cross plans, Anthem, United, many others have piloted alternative payment models such as the Blue Cross Blue Shield Association Blue Distinction Specialty Care Program that, again, are intended to align payments with better care, with value. And all of that, of course, leads to what constitutes values. Value-based payment is intended to include new steps to try to get total cost of care down through new flexibilities in delivering care. But along with that comes some more accountability for total cost of care. And so it's important to balance the accountability for cost with some steps to make sure that patients really are getting the kind of care that they want. And that's been hard historically with an absence of such measures, even in traditional healthcare models. It's especially important as we try to do a much better job of changing cancer care so it's more responsive to getting patients what they want, what they need at a lower overall cost. So on the next slide, there's a little bit of an introduction to the focus of the paper that NPC and Discern has released on the notion of going from patient-reported measures, which includes patient-reported outcome measures that capture experience and patient outcomes, to patient-reported performance measures to build in to the assessment of the function of these payment reforms and to provide better information, hopefully to guide providers, to guide patients about what really matters to patients, and making sure that is incorporated in the payment reforms and the goals of the care reforms that the payment reforms are intended to support. This is especially important in oncology because of just how important, how serious this condition can be, and how much burden it can impose physically, psychologically, in terms of costs on patients and their families. And also because, as I mentioned at the outset, there really are opportunities to improve the overall experience and quality of care and outcomes for patients. And no better place to get information on how these efforts to deliver better care are actually doing than from patients. So in this report, we focus on patient-reported measures to help bring patient voices into these payment reforms and accountability programs. So it emphasized, too, that it's not just accountability in the form of affecting payments in these value-based payment models, but it also can be useful for accountability for patient confidence, letting them know which care really is better, which care really reflects their own priorities, so they can make better decisions based on accountability as well. The patient-reported measures are tools like surveys that can capture patient voices related to their care experience and outcomes. This is different than patient-reported outcome measures alone, which tend to focus, by definition only on outcomes. A lot of other dimensions of performance where patient input can be really helpful. And as the report describes, the patient-reported performance measures translate these patient-reported measure responses into metrics that can be used to assess the performance of providers in a payment reform model, to influence their payment, that can be used to help make decisions about which providers to use more informed, and to help provide some feedback on whether the efforts that we all are undertaking, patients and their choices, providers and the efforts they're taking to try to improve care, how they're actually doing and how they might improve over time. So I think on the next slide, we talk about we're going to go into more detail in how these, what the opportunities and challenges are in applying these models in payment programs like the oncology care model and like the growing number of commercial models that seek to get better care through payment reform, where these patient-reported performance measures can be an absolutely critical part of the future. And to do that, I'd like to introduce Ethan Basch. You heard his brief bio before. Ethan is an expert in these areas of performance measurement. And Ethan, I'd like to turn to you to talk about some of the opportunities and challenges on whether the measures we have and the measures that we could potentially develop really can capture value for patients in a way that drives all of these payment reform and care reform efforts forward.
Thanks so much, Mark. I appreciate that. So I'm going to provide a little bit of insight on the evidence around these kinds of metrics and also some of their more broad uses. So the first thing I would say is that implementing patient-reported metrics, and particularly patient-reported performance metrics, as Mark outlined, can have additional benefits in oncology care besides provider accountability. These measures can also be used during active management for cancers to improve the quality of care and to improve outcomes, as well as for quality improvement. So, for example, I and others have worked closely with ASCO and with other national organizations to develop patient-reported outcome performance measures in oncology. For example, to assess the proportion of patients with post-chemotherapy nausea, the proportion of patients with poorly controlled pain who are not being managed with analgesics, the preventable excess of constipation among patients receiving active therapy, et cetera. These have been tested nationally. They're currently in use in a number of contexts, including throughout the state of Minnesota as a part of their statewide quality program across diseases. I would also note that implementation of patient-reported outcomes in oncology has been associated with improved symptom control, emergency room visits, patient satisfaction, quality of life, overall survival, and longer duration and tolerability of chemotherapy. So this slide alludes to mounting evidence from a number of clinical trials now demonstrating that implementation of patient-reported outcomes in clinical practice to monitor patient symptoms, physical functioning, and other elements of their status to enhance communication with providers can have substantial downstream benefits. There have now been 2 randomized controlled trials published showing a survival benefit, but all of these benefits shown in the bulleted points have been demonstrated now by an abundance of prospective studies. Now, the caveat on the bottom of this slide is that this really has to be done thoughtfully. The measures that are used need to be fit or appropriate to the purpose or context of use. The outcomes being assessed, the PROs need to be meaningful to a patient population, and implementation has to be done appropriately, generally through electronic data capture, ideally tethered to the electronic health record, so that providers can have ongoing access to patient-reported data. Now, in spite of these potential benefits, there are substantial existing barriers to implementing PROs in practice and to implementing PROs for performance measurement in value-based payment programs and more broadly in oncology. The first barrier is technology. As I just noted, ideally, this information will be collected electronically and linked to a patient portal or the electronic health record. But this technology is nascent. Two of the major EHR vendors do have patient-reported outcome data collection functionality, but it's still early, and it requires customization at the individual practice level in order to make it function smoothly. The second barrier is workflow. We don't routinely collect this information in our practices, and so getting staff and clinicians as well as patients up to speed and oriented and activated to be involved with this endeavor takes work. And then the third is the challenge that is shown in the caveat on the bottom, the selection of the items, to make sure that what you are collecting from patients is meaningful and informative. So the study that was conducted by the group on this call with NPC and Discern highlights many of these barriers and makes recommendations for advancing the use of patient-reported outcome performance measures in value-based programs. It provides many helpful insights. It reviews the literature and past experiences, and is really, I'd say, extremely helpful and prescriptive for organizations that are interested to move forward in this area. And as policymakers work to incentivize providers to deliver value in healthcare, it becomes ever more important to ensure that the measures that we use to capture value reflect the voices and perspectives of patients and caregivers. With that, I will hand it over to Teresa.
Well, thank you so much to Ethan and Mark for sharing some of the overarching healthcare background related to patient-reported measures, and specifically patient-reported measures in oncology. I'm not going to spend a huge amount of time talking about the project and our findings, because we really do encourage you to download the white paper, and the link will be available in the slides and also from the NPC and Discern websites. However, to set up the conversation and the panel discussion that is to follow, I would like to share a little bit of background. As Kimberly mentioned, the goal of this research was to assess the current landscape of patient-reported measures in oncology and identify those strategies for developing and/or enhancing these measures for use in accountable care programs. My role was to lead the project at Discern Health and collaborate closely with our co-authors and my colleagues, Tom Balick, who's a partner at Discern, Brittany Perkins, and Palak Patel, who are research analysts. So in addition to the literature review that Ethan mentioned, we also developed a framework and performed a landscape scan to identify the available measures that are currently today in use and have already been developed that could potentially be used in both value-based programs, but also for clinical practice and for quality improvement. We then conducted interviews with roundtable participants and other stakeholders and experts in oncology care and in measurement. We administered a survey to some of the participants that we then involved in a roundtable discussion. This multi-stakeholder convening brought together patients and expert stakeholders to discuss this topic and to develop recommendations for filling measurement gaps and removing those barriers that Ethan referenced to patient-reported measure implementation in accountable care programs. So all of these inputs together were used to develop the white paper and to set the stage for continuing the discussion today. So the organizing framework that we developed to assess the landscape and identify gaps had three components. First of all, the measure population, were the measures specific to oncology patients or oncologists, or were the measures cross-cutting? Were they measures for a broader population that could be applied to oncology patients? The second was phases of cancer care. This drew heavily from the patient-focused episode of care model for cancer care from NQF, and it also referenced the National Voluntary Consensus Standards for Quality of Cancer Care. The three phases we identified were the population at risk phase, the evaluation and initial management phase, which includes both diagnosis and treatment, and then the follow-up care phase, which includes moving from active treatment to either survivorship or to end-of-life care. Finally, we identified from various different sources 14 measure domains, which were broadly categorized into quality of life domains and experience of care domains. And by developing this framework, we were able to catalog the landscape of measures, and it supported our gap analysis to find out what was missing in the landscape. So on the next slide, you'll see an overview of our findings by the numbers. So if you look at the measures summary and read right to left, you'll see that we identified over 800 patient-reported performance measures. Out of these, there were 515 cross-cutting measures that were applicable to oncology, and only 18 that were specific to oncology. So what you'll notice is that this measure is, this list of measures is actually longer than the number of patient-reported measures that we found. And of course, these are the instruments, the surveys, the tools. And that's because multiple performance measures might come from a single instrument. So we identified 261 already created patient-reported measures for both cross-cutting and oncology populations. But many of these, again, came from the same source. So many of you are familiar with the functional assessment of cancer therapy, and the FACT tool has a general cancer survey, but additional specific to breast cancer, for example. So the general survey and that cluster of different instruments together, we classified as parent PRM. So there were about 100 of those. And the graphic shows you how it would break down from the bigger parent PRM to the individual versions of the survey that might be administered or other instruments to the performance measures that might come from one of those versions. So one of the questions we asked our survey respondents is, given what's out there and what you know about and what you've worked with, what are the most promising patient-reported measures that might be good sources for additional performance measures, especially in oncology and especially for use in accountable care? So the ones listed on this slide on the right were the answers. And the starred PRMs also received votes of confidence for validity and generalizability by a 2018 MedCAC panel for CAR T therapy that many of our roundtable participants also participated in. So there are some promising surveys out there and other instruments, but the question is, what are the gaps that remain? So on the next slide, you'll see our answer to this question. We applied our framework to identify what care phases and what domains currently have measures, both PRMs and PRPMs. We coded for each one all of the care phases and domains that applied, and in that way we identified where the gaps were. So we also looked at the content and use and accountability programs to identify additional gaps, not just looking at the numbers, but looking at what was available that would be applicable to the needs in oncology. So the domains of goal attainment and care concordance, socioeconomic status specifically related to financial burden, personalized medicine care planning, and caregiver burden were all identified as gaps. And you'll notice the caregiver burden at the bottom of the slide and to the right. There are actually quite a number of cross-cutting PRPMs, but most of these were related to the caregiver's report of the patient's care as opposed to the burden that care places on the caregivers or the families. We also noticed that most oncology measures fell into the evaluation and initial management phase of cancer care, which of course encompasses diagnosis and treatment, but there were very few in population at risk and follow-up care phases. In both our interviews and in the roundtable, survivorship emerged as a major gap that could be filled with additional measures. So then on the next slide, in looking at this framework, we also considered prior projects from Discern and NPC, wherein we described a layered measurement approach for assessing the use of measures. And building on this approach, we observed that PRMs and PRPMs can be used to enhance clinical care at the provider level, drive, measure quality improvement at the provider and system levels, and assess performance for accountability purposes at the provider, system, and accountability/population levels. So many of the benefits that Ethan described were focused on enhancing clinical care at the provider level, but as he mentioned, there are also benefits for using PRPMs at all three of these levels, and our webinar today focuses on the use for accountability. In that vein, we discovered 7 patient-reported performance measures that had been implemented in accountability programs relevant to oncologists. These programs are listed on the right-hand side of the slide. So on the next slide, Ethan already began talking about some of the barriers, especially the barriers related to provider resources. Providers have insufficient resources often, such as staff and especially technology, to collect, report, and analyze measured data related to patient-reported performance measures. And this goes hand in hand with the fact that many of the accountability programs that built in these measures didn't also incentivize implementation. So providers are held accountable for performance, but aren't given additional resources up front to make the changes that they need to support this. In addition to provider burden, patient burden and survey fatigue is a barrier that many of our interviewees and roundtable participants discussed. Methodology, Ethan has already outlined some of the concerns with scientifically valid measures. And there are many methodological considerations in selecting measures, especially for value-based payment programs. And then finally, and perhaps most importantly, the meaningfulness of measures. As Mark mentioned, available measures do not always measure concepts that are meaningful to patients and families. So my last slide discusses the recommendations that we advanced in this webinar and in the paper. So many of these recommendations will be discussed in the panel discussion that follows. We hope to involve patients and caregivers throughout all aspects of the measure's life cycle to ensure the measures capture value. This could include, from a policy standpoint, funding for patient engagement, requirements for patient involvement, and involvement of patients in evaluation of programs, not just design of programs. We also recommend addressing some of these methodological challenges, ensuring they meet high standards of scientific rigor. And these are discussed in more detail in the white paper as well. We also recommend reducing provider and patient burden by offering standardized PRMs and PRPMs. So as we'll talk about additionally in our panel discussion, patients aren't completing quite as many surveys and providers aren't tracking to quite as many measures. we'll also recommend supporting providers in PRM and PRPM implementation, offer grants, offer training, offer additional incentives, subsidize technologies and other resources, create incentives for technology vendors to incorporate standardized PRMs, and then finally, fill care phase and domain gaps. A couple slides ago, I shared some of the gaps that we found, and identifying and developing measures to meet those needs and meet the prioritized needs of patients that we outline earlier in the webinar today, but also in the paper, is one of our key recommendations from this report. So with that background, I'll turn it back over to Mark and to the panelists for their reflections on these recommendations and their experiences in the space. Thank you.
All right, Teresa, thank you very much. That was a lot of ground to cover, and did it very concisely. As I think you can see, there is a foundation to build on here in terms of existing measures, and the framework that Teresa described identified some gaps in it, but also some opportunities to build on, and that led to the major recommendations that she just went through. Here, we want to tease out the thinking behind some of the recommendations, and especially how we can make more progress on them with some people who bring some very special perspectives to this discussion. You've already met Ethan Basch earlier in this webinar. We also have with us Garth Callaghan, who has some direct experience as a cancer patient. Sally Oken has a tremendous career and history and advocacy and providing new kinds of support for patients. Andy Baskin, who's been involved in many of the kinds of value-based payment reforms that we've talked about here and more generally, and Ann Fish-Stagel, who represents a clinical and specialty pharmacy perspective, also very important in getting to better outcomes and finding a part of a new care model. So I've introduced you all again briefly. Maybe aside from Ethan, who's already had a chance to talk a bit about his experience with patient-reported measures, maybe I could turn to each of the rest of you for a little bit more about your background related to cancer care and measurement, and how you've engaged with patient-reported measures. And Garth, I'd sure like to start with you.
Well, thank you for asking, and thanks for having me today. I have been a cancer patient since late 2011. And I've had a doctor look me in the eye 7 different times and say, Mr. Callahan, you have cancer. And through this, I've had, I think, 75 CTs and MRIs, a couple of operations, 1,621 days of daily chemotherapy. And with almost each and every single appointment or interaction, I receive at least one survey, and the survey is often mailed to me, and sometimes I can't tell if it's a bill, an EOB, or a survey. And I'm literally looking at a stack on my desk right now of paperwork from my current healthcare provider, and I couldn't tell you which is which. So I've had the opportunity to fill out quite a bit of these as an ongoing patient.
Great. Well, I definitely want to follow up on that experience, and probably not a good sign if the survey instruments look like EOBs. Sally, could I turn to you next?
Absolutely, sure. So I'm Sally Oken, and I am an RN. I've been a former oncology nurse a number of years ago, but spent a good portion of my career as a community-based palliative care specialist, oftentimes working with patients with cancer diagnoses. For the last 11 years, I've been working at Patients Like Me, which is an online patient-powered research network. We cover a host of different conditions, of which some conditions are cancer related. And really our focus has been on creating an environment within which we collect patient data directly from people to measure not only their own experiences with their symptoms and conditions, but also in many situations and different studies that we've done to measure how well their care has been, whether it was aligned with the kind of quality measures that one would expect for that type of care and condition. So it's been a unique opportunity to work in an environment where we're directly interacting with patients living with many long-term chronic conditions, many cancer patients as well, to gather the patient voice in a way that we can make it relevant, not only in research, but also in care, by coding that data in ways that would become clinically relevant, and having a way of being able to translate the patient voice using their verbatim into something that's more familiar for clinicians. So it's been a great opportunity to kind of push the science on patient input as we've developed patients like me over the years. So thank you.
Yeah, thank you, and some great practical tools and insights. Andy, could I turn to you next?
Sure. Thanks, Mark. So hi, everybody. I'm an internist. I practiced as a primary care physician for about close to 20 years, and I've been at Aetna for 20 years, the last 10 of which is the National Medical Director for Clinical Quality. Certainly in that role, our use of our experience with patient-reported measurement is actually rather limited, believe it or not. You're all familiar with CAP surveys, and it works great at a health plan level, but not very good at the level that we're talking about here. And we certainly have an oncology medical home program that does utilize some patient-reported outcomes. But related experience in measurement, I currently am on and have been since the beginning of the steering committee, the Core Quality Measure Collaborative, which many of you may be familiar with. And I'm a longstanding, I can't remember how many years, but it's 6+ years on NCQA's HEDIS committee, which is technically called the Committee for Performance Measurement, where we talk a lot about these types of issues. And currently doing a lot of work as steering committee on something called the Patient Perspective Value Framework Initiative, which was initiated by Faster Cures, which is very interesting, and that's a shared decision-making tool that really goes deep into the patient perspective, but lends itself to measurement as kind of a next step. Thank you.
Great. Thanks very much. And Anne, could I turn to you next?
Absolutely. Thank you so much for the opportunity to join this panel today. I have been an oncology nurse for more than 35 years now. I spent 27 of those years in academic medicine at UNC Chapel Hill in various roles, including clinical research and sort of pioneering the oncology navigator role. And for the last 10 years, I've been at Biologics, which is primarily an oncology specialty pharmacy in Cary that serves nationwide. And my role here has been to develop patient management programs for patients on oral therapy. So we have concentrated on not burdening our providers. So all of the data that we really collect is that of our patients. So I've been extremely excited as this new world of patient-reported outcomes has become bigger and better over the last couple of years, because that's the world that we live in specialty pharmacy. So very excited to take that data and move it to the next level of patient care.
Thanks, Anne. Great to have you with us. I'd like to start out this discussion with Garth. I mean, you talked about your experience with what sounds like a whole series of patient surveys so far. It sounds like they haven't quite gotten the message that Sally conveyed, that it is possible to do more efficient and effective direct data collection from patients, and Anne's point that one way to not burden providers but still get information that's really useful for them and for improving care is going directly from patients. So Garth, despite that experience, what do you think about the appropriateness of having payment affected by how you and other patients like you respond to these types of questions, to move payments in the direction of focusing more directly on what matters to patients?
So to be honest, it scares the heck out of me. And part of the reason is I understand that when we ask about influencing payments, that they could be influenced both negatively and positively, at least in terms of the doctor's or the practice's viewpoint. And in my experience, patients who fill out surveys, typically they typically have incentive to fill out the survey. They've either had a really, really good experience or a really, really bad experience. And for those bulk of the patients who are right in the middle of the bell curve, who don't really have a lot to say, the survey gets unanswered, especially oncology patients. We're too tired. We have too many things going on and too many pieces of friction in our lives to really bother with a survey if we don't think that it's going to matter.
Yeah. And Sally, maybe I could turn to you, because you all have done at Patients Like Me a tremendous amount of work to try to engage a broad spectrum of patients. Maybe you could comment a little on steps that you think are helpful in addressing the kinds of concerns that Garth has raised about making sure that these that any data from patients really is representative and meaningful. And also on the other side of that, to what extent are patients and families aware of quality measures, payment measures, these kinds of performance measures? Are we, and what, I'm going to get to what we can do to help get there further, but really like your perspective on where we are now with respect to Garth's kinds of concerns and the potential value of the information on value.
Yeah, it's a great question, and I think when you think about how much awareness a patient or a caregiver might have about the kinds of things that we're measuring that might have some relationship to the value of the care they're getting and the quality of their care they're getting, I would say it's probably pretty limited, unless the providers themselves have taken the time to explain why they might be gathering some bits of information. And in Garth's situation, we already know that the kinds of things that he's got in front of him, sometimes he's not quite sure exactly, what the use will be. So I think the likelihood of them having a familiarity with a survey of some sort after a clinical encounter is probably high. However, how that fits into the scheme of things is probably low. And I think that's on providers. I think that's on the system to have a better sense of how patients and their caregivers want to be more of a participant in improving quality and getting better value for their care. So our experience has been that people would like to contribute to that in ways that actually do help their providers perform better, but they're not so sure how to go about that. And I think this is a great opportunity to identify different ways of doing that kind of engagement with your patients and your caregivers to really get a better understanding of how might what we're gathering in terms of the measures that we have to be accountable for, really weave into the overall understanding of how your care and the quality of your care can be improved through us engaging about it. So I think we have a lot to do in that area, but I think patients and caregivers are typically welcoming that kind of idea to support Garth's point. They're tired and they want to be sure that there's an efficiency to the care that they're getting in ways that actually does have some improvement in the kinds of things that matter most to them.
Yeah, Ethan, maybe this is a good point to turn to you as both a provider and someone who's worked really hard on developing and using patient-reported measures. So we've talked some, and you talked in your remarks some about the important reasons to include these measures and potentially include them in value-based payment programs. But we've also just heard about some very real challenges in terms of actually collecting the data reliably without too much burden on patients, and methodologic, or are we getting valid responses, and impact. Are people really paying attention? What do you see as some of the biggest challenges here, and maybe even better, maybe some things we could do to overcome them?
Yeah, absolutely. Thanks for the question, Mark. I think first of all, there's no question that collecting this information is essential in value-based models of care, right? The purpose of delivering care in cancer, particularly in patients with advanced or metastatic disease, is to lengthen life, but very often is to improve how people feel and how they function. And if we don't collect information about how people are feeling and functioning, we really can't evaluate how that care is going, and variation between practices, things we can do to improve practice. And unfortunately, we know that much of the time, symptoms are not monitored or managed adequately, and people suffer at home, and this can lead to downstream problems like avoidable hospitalizations and ER visits or dose modifications, et cetera. So to me, I think I think the conclusion is that the information is valuable. So then I think that brings us to the second question that that Garth was alluding to, which is, what are the challenges in collecting this information? I'm very sensitive to Garth's comments. There are so many difficulties and challenges involved with being a patient, and to just add something else on top of that, an additional obligation or burden, is very challenging, and this leads to the real risk of informative missing data, right? That the patients are the most well or the most disgruntled or the most happy will report. That's the same with any survey research. What I would say in the work that has been done that's thoughtful, and I tried to allude to this earlier, is that methods exist to systematically collect this information across populations with ways to minimize the burden, optimize compliance so that there's truly a representative sample. And in many of the studies that have been done, upwards of 90% of patients report on their health status at any given time point, sometimes more than that. And so we can have confidence that those are representative samples. I think where we get into trouble is when these programs are not implemented thoughtfully. The technology is burdensome. They require long passwords. They're, excessively long questionnaires. The questions are not salient to patients. The patients feel nobody's looking at it. It's not tied into practice. And, when those things happen, the compliance rates go way down. And then we really do worry about the kinds of issues that Garth alluded to, the informative missing data. And we have to really question how meaningful those data are. But, I would say that, as outlined in the report, methods exist today to optimize response rates, to have a representative sample so that we can have meaningful information for value.
Mm-hmm. Thanks very much, Ethan. And that, Andy, I think that brings me to you, because you actually have implemented a number of patient-reported measures in programs to help improve quality of care by providers and payment. So I expect you've had to work through some of the challenges that Ethan described, maybe with some of those kinds of steps to the point that you get confident enough in the measures, and they're not too burdensome to introduce, but those are challenging steps, and maybe that's partly why we don't see more of these measures now. Maybe you could comment on some of your experience with actually including patient-reported measures in payment programs and care improvement programs.
Sure, thank you. And I wish I could start out by saying that we've solved all of those challenges, but we have not. And perhaps a short case example would illustrate what some of those challenges are. So we have something called an oncology medical home program. So we work with 30 plus, I think soon to be 50 plus practices who have a relationship with us, and it's a value-based relationship. Part of that relationship is the practice is required to utilize some sort of member survey. We actually don't get very prescriptive about that. And the reason we don't is because I'm one payer. I may represent 5, 10%, maybe lucky in a big market, 20% of a practice, but there's at least another 5 payers out there as large as I am that are also asking them to do something similar. So that, frankly, I have practices using any of the number of standard surveys out there, tools that they select. There may be 4 or 5 that are used. The methodologies vary. Some are point of care, some are post-service. Providers prefer the point of care because it helps them in their literally the day-to-day activity in real time. But post-service is used for performance measurement, probably much easier. So there's tension there. Currently, it's very hard to incentivize for the results because different surveys are used. So aggregation is nil, benchmarking is nil. So improvement has to be basically improvement upon yourself, which is good, but limited when you're trying to administer a bigger program and improve the quality of care that goes across whole regions of the country. So great difficulties there because single payer solutions are difficult. As I said, they don't lend themselves much to benchmarking, which is really problematic, and don't lend themselves to public reporting, which right now can't easily be done. And public reporting is very beneficial to inform patients to make decisions, inform purchasers who are purchasing care, and policymakers. So very difficult. In terms of even selecting the measures, frankly, I don't know that you want your health plan or payer to select the measures, especially to get the patient input into what are the appropriate measures. Is frankly, we shouldn't be competing on what's important to patients. We should all be using similar patient preferred measures.
Yeah, and just to follow up on that, I mean, this does touch on some of the recommendations in the report related to encouraging more alignment. Actually, we've got a slide up on that right now. It sounds like you would actually like to see public payers like Medicare and maybe a publicly driven process getting to more consistency in how the how measures are used.
Well, I certainly like to see a widespread process that we all kind of buy into, multi-stakeholder, whether that should be a public lead on that one, or whether it should be a private-public kind of partnership, or even developed in the private world and then let the public plan borrow upon that. I think that remains to be seen what's the best way to do that. Yeah, I mean, certainly if you've had your experience with CAP surveys, which we've all tried to improve upon or change or, evolve as time has gone on, that's been a very difficult process. I worry somewhat about a public process, which is not as flexible.
Got it. Well, I want to come back to some of these challenges, but let me ask Anne first. So you're working with a lot of patients, kind of a growing number of cancer patients who are on oral medications. Anne, could you say a bit more about how you're integrating patient-reported measures into your processes around care delivery and your insights about addressing some of the challenges we've just been describing?
Absolutely, Mark. We have been obviously talking to patients for quite a long time, and I think that that's something that's a misperception, that a lot of people don't realize that a pharmacy is actually considered a provider. And our clinicians are beholden to their licenses, much like that in any practice. So we feel very, very strongly about the expensive and potentially life-saving medications that we dispense to these patients, and hold that responsibility closely in making sure that those patients have the best journey that they can have. And in doing so, we really have tried to develop tools. Internally, we call them assessments. You could call them surveys, but we've really tried to develop tools that get to the heart of what keeps a patient on therapy as long as it's beneficial, with as best quality of life as possible. So that's sort of our why, if you will, and then thinking that the patient is really our true north. When patient outcomes are better, then we know that we have done the right thing in designing these tools. And the way I really train our staff, because we have not to this point implemented surveys where the patient actually has to fill out something, but we certainly are moving in that direction to implement an ePro tool. And we don't necessarily want that to take the place of our personal phone calls from our pharmacists and nurses. But what we really want to do is give patients, especially younger patients who are very technology savvy, a different way to engage. Because I think really the important thing for us is that we get that patient to engage. And we know that when patients do engage, as Ethan said earlier, then our outcomes are better. So really for us, it's focusing on what are those things that really affect adherence and quality of life, doing that right now telephonically and then looking at other options for patients to engage. We also want to keep our providers or our prescribers in mind, because we do fill a gap in that period of time between visits, especially for patients who are on orals. So anything that we think is relevant to that patient's journey, we want to make sure that we communicate that back to their prescribing physician. Last but not least in this is that we do collect a lot of clinical data around these patients that can be shared not only with payers, but also with the manufacturers.
Mm-hmm. So, I mean, that's certainly a value of the data you're collecting to payers, to manufacturers, and it sounds like to providers as well. So trying to limit the burden of any collection that they do, but also feeding back the information to them. Sounds like a good way to increase the value of this process. Just to follow up on this, though, Ann, have you found that there are steps that payers can take to make it easier to include these kinds of patient-reported performance measures?
I think that one of the things that we've done as a specialty pharmacy is to really talk to our payers when we're looking at payer contracts. I heard what Andy said, and I think that's really important that we all try to come together to ask the same questions. Are we collecting the same data? So that's one of the things that we've really worked hard in our contracts to remain consistent across our payer contracts, so that each of those payer contracts includes the same data. The surveys or the assessments that we use for our patients are very standard. We want our clinicians to be able to weave those questions into a conversational aspect of the patients. We don't ask them point blank to answer questions. It's really a head-to-toe assessment of patients, much like we would do at the bedside, but we weave in those questions that are data collectibles for our payer contract. So consistency to me is really important in this process, so that we're all looking at the same data.
Yeah, and you're in a position, you're working with a number of payers where you really can get at some of the points that have been raised before about the challenges and burdens of inconsistent reporting. It sounds like you found some ways to get multiple payers to support that approach.
We have. We have. We've kept it simple. We've kept it to a minimum of 4 or 5 questions, and we ask the same questions of all patients regardless of their payer status. And really, some of that is about ER visits. It's about urgent care visits. It's about their experience in calling their prescriber provider's office and whether or not they were able to get through. So those are some of the things that we're looking at and sharing with payers, but at the same time, that helps us improve that patient journey and experience as well.
Yeah, so Ethan, turning to you. So this theme of consistency around meaningful, simple questions, that's one way to maybe reduce the burden on providers and when they're helping to implement patient-reported measures. Can you talk a bit more about ways to reduce burden on providers and any advice you might have for payers as they try to move forward in applying these kinds of measures?
Sure. So the first thing is that the information collected, if it's going to be conveyed back to providers in clinical practice, needs to be actionable and meaningful. As providers, we are involved in managing patient symptoms and side effects, and in general, in evaluations of these kinds of programs, providers have been very satisfied when they receive this information back about their specific patients towards management. And indeed, it's been found that the overall amount of time providers spend with patients has not increased, because these systems tend to prevent downstream complications that take up a lot of time. So you spend your time up front rather than on the back end when people get into trouble from their poorly controlled symptoms. In terms of quality improvement or quality programs or value-based programs, the information that's fed back in aggregate to providers and practices about patient status, again, needs to be actionable and needs to be meaningful. So it's been found with programs implementing patient-reported outcome performance measures that if areas are measured that providers can't really do anything about, or they feel it's out of their control, it's related to transportation or societal trends or social determinants of health, and it's outside of their control, that tends to lead to frustration. If you're measuring things like pain control or nausea control, things that we routinely deal with, pointing out to a provider or a practice that we're falling short compared to our peers can be extremely helpful, and that's generally received well.
Yeah, no, social factors can be important, but I understand the distinction between, setting up appropriate systems for dealing with those obstacles versus what most providers today think they're capable of addressing. And Andy, maybe based on what you've been hearing in terms of suggestions for how health plans can support providers in implementing these patient-reported measures, would like your perspective on all of this. Anything you'd like to add or distinguish?
Yeah, sure. Just a couple of points. So I mean, the direct financing is there's not much to that. Is there enough incentive in a value-based purchasing program to do that? I suspect today there's not. So I don't think that's necessarily the best thing that we can do, but there's other indirect ways to support this. I mean, the ability of a health plan to accept information that comes through a registry. So, a lot of practices now are reporting into registries. Should that be enough, and should I be able to get that information out of the registry and not create an extra expense? That would be great. Direct reporting from electronic health records, direct reporting through some data clearinghouses. There's vendors out there that do that for reporting to CMS, and could that same information or those measures come out of those particular solutions? Once again, very cost effective, doesn't increase incrementally the cost too much because those solutions are already being utilized by practices. The other things we can do is basically come up with common measure sets, common methodologies, basically reduce variability across all the payers, and variability is costly, and reduction of variability is a savings. So those are some of the quick hit ideas.
Great, thank you. And Garth, you've been listening to a lot of these comments, and I go back to where we started with you. That from your standpoint, at least in your own experience, the surveys you're getting just don't seem to be doing it for you. Based on what you've heard, maybe some additional points you'd like to make. What would make the efforts to get more information from you more meaningful?
Well, I think I kind of rank surveys in three different ways. One is it digital? Because that's probably a survey that is going to at least aggregate data and possibly either help me or help another patient. Is it paper-based in the doctor's office? Again, I feel at least at that point somebody's probably going to take a look at it. And then is it paper-based at my home? In which case I know that there's not really a good likelihood that it's going to get filled out. And if I happen to mail it, I have no idea what happened. I have no idea what goes on after that. So getting some immediate feedback is really important. So if a nurse or somebody in the practice hands me a tablet and says, "Hey, Garth, we want you to take this survey. It's going to help us determine your mental health state right now. And if we find that you need additional help afterwards, we're going to point you in the right direction." So they're giving me both the, "Hey, here's a survey, and if we find something, we're going to help you." And that's really important to get that immediate feedback that there is a purpose behind it.
Yeah, that's really the counterpoint to that actionability theme that we heard in several of the other comments. And clearly, point of care, digital, easy to use, along with that meaningfulness matters to you. Sally, maybe I can ask you, since you have an awful lot of experience working with patients to get meaningful data. Your thoughts about how to make these kinds of measures for cancer care more meaningful and more widely used?
Yeah, I'm going to probably be repeating some of the things that have already been said, but I'm going to put it in the context of the fact that we have actually asked our patients, and they've informed us on the principles of measurement that they think are most important. And so the things that they've said to us are, I want to be able to answer the question. So make it answerable, make sure I have that kind of information available. I want it to be clear so I understand what it means. It should respect my time and be efficient. They'd like to be sure that it describes their experience in some way to make it relevant, not unlike what Garth was just describing around their mental health status and how they're feeling. They really like to learn something. So is there something about this survey that actually could educate me about something I didn't know before about my condition? And they're sensitive to having the survey make them more sad or symptomatic than they were before they took the survey. And then lastly, and we've heard this now a number of times, they really want something that's actionable, that either helps them understand what they might be able to do to ameliorate their symptom or identify a way of discussing it with their provider, so that they can really put this into the context of them as a whole person. And that's something that has come through repeatedly for our patients when we've asked them specifically, what are the principles of measurement and how might we design those in ways that are actually going to be best for you? And I think Garth actually pointed to some of the things that they've told us in terms of being able to have it be useful in an environment that they can complete the survey and know that it's going to go someplace and have it be used.
Great summary. Thanks very much. So we've had a really good discussion about better ways to collect the information and how to make sure it can be, in fact, actionable. I do want to turn to some of the gap areas that were demonstrated in the report. So to go back, I see we've got a slide up on it now. The stakeholders who were surveyed as part of this effort had some high priority areas where they didn't think that the measures were there now, that met the kind of conditions that Sally and all the rest of you were just describing. So in particular, these included whether symptoms were interfering with daily activities, whether symptoms and functioning information was collected and conveyed to providers. We talked about that. Garth focused in on that just a minute ago. About also a third area, provider assessed the patients for emotional, social status concerns and offered some actionable steps from it. And then fourth, patient goals and values were considered across the cancer treatment process. Ethan, you led some discussion on this topic earlier on during this webinar. Can you say a little bit more about why you think these particular areas made it to the top of the critical gap list?
Yeah, actually, I think I touched on these a little bit. I actually might turn it to Sally to comment on these first, and maybe I would comment on that after. I think that she's really in a very strong position to comment on these, if that's okay. Yeah,
Sally, your thoughts?
Sure. I think one of the things as I went through the gaps and really looking more closely at them, that stands out for me are the things that are missing are things that actually have an impact on someone's daily life. And, I love the third one because, the provider assessed patients for emotional or social status or concerns, that seems pretty heavily packed for a provider to have to think about because it also suggests that they do something about it, right? But at the same time, for a patient, it often reveals more than the encounter was intended to, set up. When a person is asked, and I used to ask this question, although it's hard to put that into a performance measure, but what keeps you up at night? It reveals and illuminates things that actually could tease out something that's really important on a person's mind that you might not have gotten at. So I actually like that third one a lot to start really unpacking that so that it doesn't feel like a burden to a provider, but it feels like an opportunity. And that opportunity then engages the patient in something that might reveal things that you can actually do something about. And it may be that they require a referral for something else, but oftentimes it's something you can actually work out with the patient together.
Yeah, Garth, what are your thoughts about these priority gap areas?
I think as a patient, my biggest issue almost for the last 6 years has been how do I manage my symptoms? How do I manage the side effects from treatment? And does that allow me to live a quote unquote normal life? And so if my providers are not asking me that question, if I'm not able to give them that feedback, and they probably can ask it in a way that I'm not necessarily thinking about reporting myself because I'm the patient, I'm not a professional. It's really important to have that feedback loop. Mm-hmm. It's also important for them to understand that I think I said this when we first met, I may not feel comfortable answering that question in a manner that is going to help them either diagnose me or alleviate a side effect or a symptom. So it really is contingent upon the provider in the survey to pull that information out. But if they're not pulling it out, I might not think to raise my hand and say, oh, I'm really having an issue with this particular side effect, because I think, this is normal. This is what every cancer patient goes through.
Yeah. Ethan, maybe I can come back to you at this point. In terms of symptoms and side effects, I mean, it does seem like something that ought to be technically feasible to collect, maybe even collect in real time or close to real time and act on it. Any additional thoughts on how, whether it's possible to make some progress on this one?
It's absolutely right, Mark. It's been shown in numerous implementation examples now that it's highly feasible to do this. Again, coming back to some of the barriers and strategies that we discussed earlier and are in the report, I think it does need to be done thoughtfully, and some of the concepts on the slide here really do need to be paid attention to. But it's feasible. It's being done, and it can be done, and it's of increasing interest across systems, particularly those that are now paying more attention to avoidable complications that patients experience because of the value-based models they may be involved with. What I would say, though, in reflecting on the discussion we've been having, is that there are really two different components of this, right? There's the collection of the information as a part of care processes, right? Collecting information from patients that goes to the provider to improve care. And then there's the quality measurement piece of it, collecting the information from patients in order to aggregate those data to understand or infer around the quality of care being delivered overall. And for the latter, if one follows the method that we commonly do for patient experiential or satisfaction measures, that information is collected from patients and is not conveyed to providers. So what we're talking about here is really a slightly different model, which is, although we are collecting the information perhaps to understand quality, it is also being used to inform clinical care, and that adds a layer of workflow and complexity.
Yeah, and one of the questions that we got in, and a comment too, a good one from our participants in the webinar, is someone who has been a cancer patient who said that she's never been offered a patient-reported outcome instrument. And thought it would be helpful for understanding his or her experience and whether that could be improved. So it sounds like this is a topic that can be addressed for both motivated by maybe by payment and supporting these new care models, but just for care improvement. And I'll take silence there as an agreement with that comment. I want to go to a couple of other topics. I know we're running a little bit short on time. It's great discussion. Would encourage people who do have other questions. I've been trying to work those in as we go along, and I'll try to do it in these last few minutes. But there are a lot of different kinds of patients out there. And Sally, maybe I could ask you. You deal with some very diverse populations. How can we make sure we're designing measures that reflect all of their needs? And I see on our slide we even got an answer to that question up here.
I think in our conversation before we talked about sort of it's a bit of a no-brainer. We need to ask, and so we really need to engage them and think about what are the things that really matter most to you. How are you feeling? How are you functioning? And are you living the life you want, given the constraints that you might be living with as a result of your condition that we can help you with, right? And we can start to work together on. So yeah, it seems like a pretty simplified answer, but I think it ultimately is down to asking the right questions, getting a sense of what people want to engage with you about that will help them better understand how they can help you take better care of them, and vice versa. So I'll leave it at that.
Yeah, and in the report, one of the recommendations was involving patients and caregivers in the design and development of the measures and the payment reform programs. Garth, let me turn to you. What would be a good way to involve people like you in the development and implementation of these measures and the payment reforms? As you said, these kind of new ways of paying and even measuring can be either not that effective or maybe even scary if patients aren't really engaged. How do we do that?
Sure. I think the best thing that you could do is to be really upfront and transparent with what's the purpose, what's the intended outcome, how is this going to help you, and how could this help other patients? And, I'm looking at the slide on the screen and I'm chuckling a little bit to myself as well, because in the 7 or 8 years that I've been going through this, not once has my wife been asked to participate in a survey. And she has had to help me fill out some of my surveys from time to time, but not once from a caregiver perspective has her input been directly solicited. And I think that could help the patient experience, because as a patient, I'm much more likely to minimize my issues, and she will look right at the doctor and say, "Oh no, Garth is lying. He's really struggling right now." But again, Sally's right. Ask them. That's the first most important step.
Yeah, and Anne, maybe you can turn to you at this point. How do you all go about involving patients as you design your data capture tools and your implementation efforts?
Well, one of the things that we've really focused in on is just through a lot of research and talking to patients and looking at our own internal aggregated data, was to really hone in on those things that we think actually affect adherence in the greatest degree. And obviously for a pharmacy, that's really the focus of our patient care. So what are the things that help a patient be more adherent? What are the things that cause patients to be less adherent to their oral therapies? And many of the things in the GAP slide are things that we've included. We've learned that patients who their disease as a whole is a burden financially to them, not just the medication that we are dispensing, but as a whole, their daily finances are very affected by their disease. That's a big deal for patients. Certainly the mitigation of side effects, the belief in whether or not this medication is going to help them, and does that benefit, is it worth the financial aspect of that? So we believe that, a lot of patient education up front to set that patient up for success is very important. We've also asked our patients in surveys, we do a satisfaction survey that's outside of ours, which is a digital survey that a third-party administrator does. And some of the things that do come back on that are the things that Garth is actually speaking to. And so we've really tried to hone in on those things like, tell me why you're asking me these questions. What are you going to do with this information? How is this going to help me going forward? So again, when our pharmacists reach out on a very first phone call to our patients, we want to set that up. We want to tell them right up front why we're calling them, what that experience from our aspect is going to be like, what kind of questions they're going to get, when they're going to receive phone calls. And that, I think, has really helped us. In the 10 years that I've been here, these tools and the questions and the content and what we've done with that data just continually morphs and changes over time. And I think that's another important aspect, is that, again, if your patient's going to be your true north voice, then listen to it. Pay attention to the data that you're collecting and make changes that improve those patients' lives.
Yeah, and Andy, any thoughts from your standpoint about the challenges and ways of overcoming the challenges of involving patients in designing and implementing these measurement programs and programs to act on the patient-reported measures?
Sure, I'll just be very brief here, because I think what everyone said is, would come from my perspective as well as a payer. Just to say that, individual payer activities in trying to get this to happen really doesn't make much sense. This is something that we would all, get together in as a group of payers within multi-stakeholder type of events, which I am very much a part of, many of them, and they all have patient voices, and when we ask them, we get answers. But the answer I hear should be the same answer every other health plan here. So yes, we want to participate, but I don't think you want individual health plans to be doing anything different from each other.
And this, thanks for that comment. I'm looking at the clock. I know we're running short on time. There's a lot of great comments here. I know there's a lot more we could discuss, but I'd like to ask you all for some final comments before we wrap up. Andy was just touching on steps that could be taken through collaborative public-private efforts, and I think Andy particularly highlighted patient voice driving those efforts to develop the measures, to get the measures implemented consistently and effectively. Before we wrap up, I'd like to ask each of you for a final thought about what would be at the top of your list for policymakers, for people at Medicare or in Congress or involved in doing some of these reforms in states. What can they do to help accelerate progress in adopting patient-reported performance measures into programs to improve payment? And as we've heard today, alongside that, sounds like if they're done right, they're also going to improve quality of care and responsiveness to individual patient needs. Maybe we can just go through with all of you. Ethan, maybe starting with you.
Sure. Well, I would say as an oncologist that it's part of my job to understand how my patients are feeling and to know how I'm doing and how my practice is doing with management of how patients are feeling. More broadly, I'd say that without patient-reported data, we have inadequate information about patient status, and we can't really characterize how well, or I'd say how the value of the care that we're delivering. In terms of advice on the policy side, I think that we know that that unless collecting this information is a requirement, that it generally won't be done. But we also know that there probably needs to be support, either with infrastructure or financial incentives to collect this information. We have seen examples of both. For example, in the draft national coverage determination for CART therapies that was just issued by CMS, there's an expectation that PROs will be collected in a registry to understand the patient experience, and that is motivating the industry to think about how to do that. And on the incentive side, there are alternative payment models that offer incentives, financial incentives when this information is collected.
Great. Thank you. Andy, you've made a few policy recommendations already. Any final thoughts?
So just quickly, there's a hunger, thirst, whichever you think is more powerful out there. Everybody wants this. Everybody knows it's important. There's tremendous intellectual incentive, patient value incentive, expectation that this is going to occur. So I don't think we need to light a fire so much as, how do you get a mechanism to make this happen? I have found that some sort of national neutral convening type of function is necessary to make this happen, to get standardization measures, methodologies, some sort of safe harbor type of situation, because for some of these collaborations to to work. And I think that's at a public-private partnership, as we've mentioned before. I mean, if you put those together, I think then solutions are possible, and solutions that will reduce variability, reduce cost, and make this a much more likely thing to occur.
Thank you. Anne, your thoughts?
Well, I would definitely echo what Andy was just saying, that I think that, at a national level, we need to come together for truly standardizing what these patient-reported measures will be and how we look at them. I think from a patient perspective, quality of life for these patients in oncology is just paramount. And so anything that we can do from the provider and the clinical level to gain information that will improve that patient's journey overall, I think is what comes to mind as my top priority.
Thank you. Sally?
Yeah, I think I think there's plenty of opportunities where we could begin to really get patients more involved in the selection and evaluation of quality measures. We've done last year or so a project with National Quality Forum where we helped them better understand what good care looked like, because we were gathering information directly from patients and getting their perspectives on this. And some of these were going to be used for performance measure development. And I think initially many of the people in the committee were a little reticent to try to figure out ways of engaging patients in ways that they could gather that data and have that be a part of measure development. But I think at the end of that project, it was quite clear that was a very valuable experience. So I think funding initiatives that support patient input, too often, patients are asked to be a token representative on a committee, and they're trying to represent every patient, and that's just not possible. What we've been able to demonstrate is that we can bring thousands of voices into an environment that when we can put those kinds of questions in front of patients, we can bring that information into a meaningful initiative to really start to represent a broader spectrum of people's experiences. But patient experience has been part of the 21st Century Cures Act. It's being expected in certain parts of the health ecosystem today, and I think we have to find better ways of funding some of those initiatives so that we can actually get patient input and put some science behind it.
Yeah, thank you. And Garth, final word for this panel discussion from you, please.
Well, and I think everybody is talking about policies and procedures, and that's exactly where the foundation needs to be. But at the end of this process, if we don't get the patients to fill out the surveys, we've failed. And so I sit around my doctor's office an awful lot, and thinking about how can we best engage in the patients in making their time valuable and understanding that their time is filled with stress. Anything that can be done in order to help facilitate a successful survey completion and not take away from a patient's time and not take away from whatever they have going on in their health concerns, that's a paramount concern for me.
And actually make clear that it is actually helping them and their caregivers with the experience. Thank you. And I'd like to thank all of you. And Ethan, you've helped me introduce this discussion today, and I'm going to turn you for a last comment on wrapping it up. I think we have a summary slide on some key takeaways from the report, I think, which are very well reflected in this discussion. But any final thoughts that you have about the takeaways and where to go from here?
I think this was a really full discussion, and I wanted to thank Teresa in particular for her work putting together the report and bringing us together, and you, Mark, for really organizing this, and thank the panelists as well for their many insights. I think that we really covered a large amount of information today, and hopefully it was helpful to the listeners.
I couldn't agree more. My thanks to all too, and come away from this realizing that we are in the early days of this work in many ways, but at the same time, there's now a very strong foundation to build on, and with some specific next steps around actionability, around alignment, and some specific steps for policymakers to just provide a little bit more momentum for something that everybody wants anyway, which is increasingly technically possible, I think we make a lot more progress. So I want to thank you all for the effort today, and thank everyone going forward for hopefully turning this report into some further action in this really critical area of improving value for patients. Kim, let me turn over to you to close out.
Thank you. Mark, Ethan, thank you so much for co-chairing this. Teresa, thank you. And thank you to our panelists, Garth, Andy, Sally, and Ann, and for your participation throughout the project, not just on the webinar today. We do have the link to the webinar on slides. And for those of you who will be at the National Quality Forum annual conference in March, we will have hard copies of the paper. We will, of course, send out a link to the paper, the slides, and the recording of the webinar when we have it available. Thank you all for joining us today. This concludes our webinar.